Good morning, everybody here, and I guess virtually as well. And so in this brief portion to start off, I will just give a brief overview of the methodology that we utilized in developing the guidelines. I think an understanding of that methodology helps with interpretation. And then I'll get into the data that contributed to our recommendations regarding the ILE dose and the outcome of preterm growth, and then data surrounding considerations of ILE composition and the outcome of growth. And then, of course, a key topic on everyone's mind, look at the data surrounding the ILE composition and development of parenteral nutrition-associated liver disease, or PNOLD, or cholestasis. As always, I want to mention that this is a team effort for sure. This is the list of the multidisciplinary group of experts who participated and contributed to developing these guidelines, so they deserve the credit as well. In terms of the methodology, regarding the types of studies that were eligible for inclusion or consideration, we only considered randomized clinical trials. We determined and decided on a publication date in the range shown here. And the clinical trial needed to focus on preterm infants for the study population. Also importantly, in terms of the exclusions, the types of studies we did not include, those were prospective observational studies, retrospective studies. For the population, we did not include infants with congenital intestinal anomalies or preterm infants who developed a surgical disease such as necrotizing enterocolitis, short bowel syndrome prior to enrollment in a study. And along those lines, we also did not include studies of infants with existing PNOLD before study entry. And so thinking of the utilization of lipids, therefore this guideline does not have content related to the 100% fish oil ILE. And just the big take home here is this guideline is focused on non-surgical preterm infants. A couple of other notes in terms of the intervention, and as I show you in the PICO format, we had to think about the fact that the multi-component or composite ILEs all have the ability to reduce the exposure to soybean oil, but by the nature of the different compositions, they don't all expose the infant to fish oil. So the vantage point that we have in the guideline is the intervention for a composition reduces the exposure to soybean oil. The other thing to keep in mind when you're developing this guideline, it's similar to a meta-analysis. The ideal scenario is that you're accumulating or conflating data, pulling it together to increase the quality of the data that you have to inform a recommendation. But in order to combine or conflate that data, there were a couple of conditions. We needed at least 3 studies, 3 clinical trials that measured the same outcome and reported that outcome using the same measure of central tendency. So those 3 things were necessary to get us to a combined analysis. The final thing on methodology, as you're going through, it's very important to pay attention to the language in the recommendation, and that varies by question. They're not all either we recommend or we do not recommend. The wording of the recommendations are informed or were informed by the data we did or did not have. So, for example, we recommend against, we recommend daily advancement, we do not recommend any specific ILE. And again, this is more than just for the ILEs. Pay attention to the wording in the recommendation, and that will help your interpretation. With that, let's look at the recommendations specifically, and starting with ILE and the outcome of growth. We had the ability to address the questions of whether dose of the ILE mattered, and separately whether composition mattered. And so in the PICO format, we're focused on the non-surgical preterm infants. For dose, the intervention was a higher dose compared to the comparison or control group, the lower dose. And for the composition, again, the intervention was that reduced exposure to soybean oil. This table breaks down the interventions that I mentioned, the number of individual clinical trials that were potentially available to inform a recommendation, whether or not a combined analysis was possible, and you can see that that was not possible for either of these questions. And then some notes about individual study findings. So for dose, while it seems that we would have had 7 clinical trials, in fact, only 2 of them exclusively intervened on dose. And so, in fact, we did not have a large number of trials to hone in on the effect of dose. In a single study, the higher dose was more favorable for a couple of growth outcomes during NICU hospitalization. For the composition, we had a fairly large number of studies, and yet still a combined analysis was not possible, and that gets to the heterogeneity in reporting of outcomes, and that inhibits the ability to conflate. Still, in terms of a single study, the change in standard deviation score in length and occipitofrontal circumference during NICU hospitalization was in favor of the multi-component ILE containing fish oil. With that background, the recommendations for dose was a daily advancement of ILE to a dose of 3 grams per kilogram per day, whether you're using soy oil ILE, 100% soy oil, or a multi-component ILE. And the rationale includes the data that I showed you, but also considerations of energy demands of the rapidly growing infant, preterm infant, and the awareness of the risks of essential fatty acid deficiency if, in some scenarios, you're lowering the dose. As far as the composition, we do not and did not recommend any specific ILE for the purposes of growth enhancement. That brings us to the question of ILE composition and the outcome of PNOLD. As I've presented the guidelines in various forums, I have realized that it's been very valuable to think about who's actually represented in these findings, specifically who is actually studied. How do we apply this in the NICU, or what's the generalizability? And while this is material that's not in the guideline, as I was getting more and more questions about this, I went back to the individual studies that informed these analyses and tabulated a couple things. First of all, there were over 700 infants that informed this combined analysis for ILE composition in PNOLD. And I went to the individual studies and looked at either the mean or median birth weight. I decided to go with birth weight as opposed to gestational age. It's another reasonable consideration. And then I created these birth weight strata that you see here, I think reasonable breakdowns for birth weight categories. And you can see that the distribution, about 80% of the infants fall in this birth weight range of 750 grams to just under 1,000 grams. It's not that there weren't infants born less than 750 grams that participated, that were included in these studies, but thinking again about that central tendency, the bulk is falling into that 750 to a kilo range, and about 20% were born greater than a kilo when looking at the mean or median reported birth weight. So it gives you a sense of who really is represented and not so represented in these studies. Now, if I were to bring up a Tony Award-winning musical at this 6 a.m. hour, as we're talking about PNOLD, you could think, who invited this guy? Have I had enough coffee? Am I in the right room? But if you have seen or heard this really timeless, remarkable production, you know this song, Seasons of Love, the main song, and it has this lyric, how do you measure a year? And as you listen or read through the lyrics, they talk about ways you can quantify or measure these moments in the year of a loved one. And in all sincerity, as I was mulling over, well, how do you measure PNOLD? That actually came to mind because It seems when you look through all the studies, there are a number of ways that people choose to define PNOLD. For example, some studies use a cutoff of greater than 26 micromoles per liter, greater than 1.5 milligrams per deciliter times 2 measures, above 2, above 50. Here's one, greater than 5 milligrams per deciliter in the first 28 days. In my own opinion, that's pretty extreme. There's something else other than PNOLD going on. It's a high value very early on. Another definition, and as we found for any study, sometimes things just aren't defined. So we had to come to a consensus as a group how we were going to approach this, back and forth, discussions, debate, and agreement to use these as the definition for PNOLD. Now, getting back to the intervention, while I mentioned in general, the intervention is a reduction in the exposure to soy oil, for the PNOLD question, we in fact had the ability to do separate combined analyses. We could look at multi-component ILEs with and without fish oil together, and then separately look at multi-component ILEs that did have fish oil. Looking at this combined analysis, this is for the intervention of the multi-component ILE with and without fish oil. And as you go through these figures, you'll see the studies individually listed on the left. You'll then see the number of infants who did or did not develop the outcome based on the intervention group. And then for a binary yes-no categorical outcome, you'll see a risk difference. And putting it all together, our overall finding was not of significance. If you need to see a p-value, that's right here. So we found no significant difference, risk difference between groups. This combined analysis is for just ILEs that did contain fish oil, and again, we saw no significant risk difference between the groups. With that information, our recommendation was for the purposes of reducing the incidence of PNOLD in preterm infants, in non-surgical preterm infants, we do not recommend any specific ILE composition. Quite simply, we didn't find evidence for that reduction in risk. And we also, as you're interpreting or thinking about these findings, it's an important context to remember that these are infants that generally don't have barriers to the introduction and advancement of their enteral feedings. Now, excuse me, for a number of interventions, we had the ability to look at what we defined as secondary outcomes. These were not part of our key 12 questions. These outcomes were prematurity-associated morbidities, other important clinical markers, morbidity, length of stay. In this table here is showing those outcomes in the first column. In the second column, these were all of the combined analyses that we were able to do, quite a number, a good situation. And it lists individually whether these were any multi-component ILEs or specifically just those with fish oil, and whether or not there was a significant risk or mean difference between groups. Mean difference would be for your continuous variables. By and large, there were no significant differences between groups. Again, the control or comparison was always 100% soybean oil, except for retinopathy of prematurity. That risk difference did favor a multi-component ILE with fish oil. And in the guideline, we state that this warrants further investigation. So to wrap up and moving forward together and thinking about how we move forward together, the best quality or the ideal situation is clinical trials or whatever data source you have that you can combine and conflate. But we were quite limited in doing that, even with what I've shown you. So the neonatal nutrition community can advance and help ourselves by coming to some understanding and potentially consensus on definitions and consistency in reporting those outcomes. As I stated, we think there we need further attention to ILE composition and risk of retinopathy. And also, as there are increasing life-sustaining and resuscitation measures being provided to the most extremely preterm infants born in the 22nd week 23rd week, we really have little understanding of what their metabolic needs, capabilities, and nutritional requirements are. So we need studies that are going to increase the inclusion of those infants.